Good afternoon. I'm glad to be here today with you and share some information about significant and fascinating topic, diseases of immunity. My name is Skorik Valeria Ruslanova. I'm Associate Professor of the Department of Pathological Anatomy and Forensic Medicine in Dnipropetrovsk Medical Academy. To start with, I'd like to recommend you to subscribe our YouTube channel. This way, you are going to be aware about all new lectures and other useful videos. So, next point is obligatory. Please register in our live chat so we can see who join us and mark your attendance. Also, feel free to write questions because I'm sure that discussion is the best way to get into the particular topic. So, let's start with immune system exactly. As you know, immune system is vital for survival because it protects us from infectious pathogens that abound in the environment. Predictably, immune deficiencies render individuals as easy prey to infections. But the immune system is itself capable of causing tissue injury and disease. Examples of disorders caused by immune responses include allergies or hypersensitivity reactions and reactions against an individual's own tissues and cells, or autoimmunity. So today we are talking about mostly these problems with immune system. To start with, I'd like you to remind main or basic points of normal structure of immune system and even normal immune response. So, organs of immune system, as you see, we have two main groups, primary and secondary. I'm sure you have already known this information, but anyway, I'd like to remind. So, primary, secondary, thymus gland, red bone marrow, lymph node and spleen. Also remind you that mostly each of these organs have a cortex and the medulla. So the same, cortex, medulla, cortex, medulla. Because each zone, cortex and medulla, has exact different meaning because fulfills different function. So, about the blood cells, what do we have here? So, white blood cells, they consist of granulocytes, eosinophils, neutrophils, and basophils, and also of lymphocytes, T, B, and natural killers. Also, we have red blood cells and platelets. But mostly in the normal immune response, these group are involved. Move on. Two main types of immunity. We have so-called innate or natural or native immunity. This type refers to defense mechanisms that are present even before infections and have evolved to specifically recognize microbes and protect multicellular organism against infection. And we have adaptive immunity, also called acquired or specific. This type consists of mechanisms that are stimulated by microbes and are capable of also recognizing non-microbial substances called antigens. So, what is the main difference? That innate immunity takes hours and adaptive immunity takes weeks, days and weeks. That's why when we make a check for antibodies according to the presence of any type of problem, any type of disease, so we are looking of antibodies. So we start our searching no less than through 5, 7, even 10 days, because the amount of these antibodies is so low or even absent at the first or during the first days of the disease. So, move on. Components. Obviously, natural and specific immunities have differences, and this difference is component that is involved in this process. So, humoral components of the innate immunity mainly is complement. Cellular are neutrophils, macrophages, and natural killers. Specific also has two types or subtypes, humoral and cellular. So, about the cell-mediated immunity. So, according to this scheme, what do we have? Firstly, cell-mediated, this is about T cell. So, different types of T cells, but anyway, is about T cell. So, first of all, as you see, dendritic cell captures microbial antigens from epithelial and tissue and transport these antigens to lymph nodes. So, exactly here, to lymph nodes. And here, this dendritic cell mature and express the high level of MHC molecules and co-stimulators. On the other hand, naive T cells recognize these MHC-associated peptide antigens displayed on dendritic cells. That's why T cells are activated to proliferate and to differentiate into effector and memory cells, which migrate to sites of infection and serve various functions in cell-mediated immunity. For example, CD4 effector T cells on the Th1 subset recognize the antigens of microbes ingested by phagocytes and activate the phagocytes to kill the microbes. Other subsets of infected cells enhance leukocyte requirement and stimulate different types of immune responses. On the other hand, CD8 cytotoxic T lymphocytes kill infected cells. Some activated T cells remain in the lymphoid organs and help B cells to produce antibodies. And some T cells differentiate into long-lived memory cells. I please you remember this. So, move on. Humoral immunity. Humoral immunity is about B cells. Always about B cells. So, what do we have here? We have here, again, naive B lymphocytes recognize antigens, and under the influence of T helper cells and other stimuli, for example, the B cells are activated to proliferate and to differentiate into antibody-secreting plasma cells. So B lymphocyte becomes plasma cell. Some of the activated B cells undergo heavy chain class switching, and some become long-lived memory cell. So, also you can see on this slide list of functions, and I'd like to mention that we have no less than 4 main types of the immunoglobulins. So we have immunoglobulins, globulins G, we have immunoglobulins M. For example, immunoglobulins G and M activate complement. Also, we have immunoglobulins A. This is mucosal immunity. And also we have immunoglobulins E. We use these immunoglobulins when we are talking about mast cells and eosinophil activation. And we will talk today about it. So again, A, E, G, and M. There are main 4. So, the major functions of immune system, we have list of 5 functions. And according to problems with this function, we have 4 main groups of problems, 4 main groups of disorders or diseases of immune system. So, first of all, hypersensitivity reaction. I state that this question is the most common question in your MCQ test. Next one, immunodeficiency disorders. This question is one of the most tricky questions because in this case you need only memorize the information. So you need to memorize the name, for example, of primary immunodeficiency disease, and memorize what problem, exact problem with immune system happens due to this situation. Autoimmune diseases and possible immune disorders. So all these 4 we discuss today during our lecture. So, move on. Hypersensitivity reactions. First of all, generally. So, what is this? So, hypersensitivity reactions can be caused by exogenous and endogenous factors. It's important to remember. Hypersensitivity reaction usually results from imbalance between the effector mechanisms of immune system and the control mechanisms that serve to normally limit such responses. Next important point, the development of hypersensitivity diseases is often associated with inheritance of particular genes. It's really common. And last one, the mechanisms of tissue injury in hypersensitivity reactions are the same as the effector mechanisms of defense against infectious pathogens. Move on. There are 4 main types of hypersensitivity reactions. Type 1, 2, 3, and 4. In some classification, you could find just numbers. In some classification, you could see the name. So immediate, antibody-mediated, immune complex-mediated, cell-mediated hypersensitivity. Anyway, you need to know all these 4. If you know just 2 or just 1, unfortunately, this is not enough. You absolutely need, or obligatory need to know all 4 types. Just 4. No, this is not actually many times, just 4. And obviously to be aware about the differences in mechanisms and what's going on with patient due to this problem. So let's discuss more deeply each type of these hypersensitivity reactions. What do we have? First of all, immediate type. Type 1 hypersensitivity. So here we have the leader role of immunoglobulins E or antibody. So also specific feature of immediate reaction is presence of 2 phases. First phase is immediate reaction and second one is late phase reaction. Right now we discuss why do we have these 2. Moreover, what processes take part also in the hypersensitivity reaction type 1? So the leader role has immunoglobulins E. Mast cells actually contain these immunoglobulins A on their surface. Next one, significant edema. You see edema. How do we see the edema on the microscopical slide? We see the empty spaces between cells. So in other words, we see increased distance between cells. Also, as you see, vasodilation due to the hyperemia, mostly arterial hyperemia, and also presence of big amount, or huge, more correctly, huge amount of eosinophils. So what about the exact mechanism? Here we have granules of histamine. So mast cell produce a lot of histamine. So this is the main vasoactive amine, and this histamine leads to edema and vascular congestion. So what do we have? Firstly, I emphasize that first exposure to allergen. So I usually give an example for my students as this is a small, really small child. And let it be girl, small girl. And this wonderful, beautiful girl, firstly, comes to your granny and see some field flowers and smell them. That's it. Nothing actually has changed. I mean, grossly. So there is no clinical manifestation. There is no problem at all. This is her first contact with allergen. And you need this remember. Never hypersensitivity reaction could appear after the first, or during, more correctly, during the first contact with allergen. So, grossly, there is no changing. But is there no changes? No change at all. So, first of all, we have activation of the T cell and probably presentation of this antigen to B cell. Next important point. I'd like you to be aware about the differences in terms. So first of all, we have antibody, we have immunoglobulins, we have antigens. All these three are proteins. And antibody and immunoglobulins are synonyms. So antibodies and immunoglobulins that are proteins that are produced by plasmacytes. And antigens are also proteins, but these proteins can't be recognized by immune system of our organism. So immune system thinks that these proteins are bad. That's why these proteins should be destroyed. So these antigens were presented for B cells by T lymphocyte. Then B cell becomes plasma cyte, and this plasma cyte synthesizes immunoglobulins E. These immunoglobulins fix or bind on the surface of the mast cell. As you see, mast cell contain a lot of pinkish granules. These pinkish granules are histamine. And next, final actually step, repeat exposure of allergen. Repeat exposure of allergen. I emphasize, I underline this situation. Only repeat exposure gives us clinical manifestation. So, what do we have? Again, the same allergen binds with immunoglobulins E on the surface of the mast cell, and this mast cell actually produce a lot of mediators. So, the most important is histamine. And this histamine gives us so-called immediate hypersensitivity reaction. So, minutes after repeat exposure of the allergen. But also, due to the presence of cytokines, we have so-called late phase reactions through 2-8 hours after repeat, exposure to allergen. That's why it's very important to use corticosteroids when we treat hypersensitivity reaction, so-called anaphylactic shock. Why? Because we need to stable the membrane of the mast cells, that these mast cells do not produce cytokines that can lead to the late phase. Not only antihistamine drugs, also it's classically we use the corticosteroids to stable the membranes of the mast cell. Move on. Primary mediators, so histamine, the main role, proteases, chemotactic factors, and cytokines, leukotrienes, and prostaglandin D2. Here the most important is prostaglandin D2. So, examples. What do we have here? So we have actually all features of inflammation. We have redness, we have tumor, we have increased temperature. Instead of pain, actually it could be painful, but normally patients does not feel pain. Hives or urticaria. Oh, one more. Here you see the changes on the face, especially under the eyes and actually whole face. If there is not only face but also neck is involved, so we can name this process like Quincke's edema. So, urticaria, classical appearance when patient touch the allergen. Another example, you see how actually huge is the complex, is the place of affected area. Next one, nut and peanut allergy, so food allergy. Classical appearance, again this face and neck is erythematosus also, and we can name like Quincke's edema. So infant and food allergy as well. Again, we see the reddish color, so we have a rash with reddish color on the face mostly, but not only. Bee sting allergy, you see how here how gross, how massive it is, and this is one of the example of late phase. So firstly it could be, for example, like this one, so, and then through several hours it becomes this size. Move on. Allergic rhinitis and conjunctivitis. Again, so classically, according to the, or caused by pollen, so spring and some part of summer, I mean August especially. So patients really suffer, so there are a lot of patients who suffer from this disease. And finally, the most classical example, this is bronchial asthma. And you see here four main steps or four main parts of this situation. So first of all, vasodilation, vascular leakage, and that's why we have edema, smooth muscle spasm, and that's why patient can't breathe out because smooth muscle spasm of the bronchi. And last one is glandular secretion. So we have increased amount of mucus in the lumen of the bronchi. That's why the lumen of the bronchi becomes more narrow compared it was before the bronchial asthma. Move on. To sum up, so macrophage eats the allergen, gives it to T cell. T cell shows it to B cell. B cell, okay, I understand, and right now I'm synthesizing, so I'm going to synthesize immunoglobulins E. And you see, mast cell is sleeping. So this cell right now is in the process. So is sleeping, and immunoglobulins E just bind with the surface. And when we have second antigen contact, secondly, so patient smells, patient feels the smell of the antigens. So these antigens are inside the organism and fix with immunoglobulins E, and we have degranulation of the mast cells. Next one, type 2, antibody-mediated hypersensitivity. So, in other words, antibody-mediated cytotoxicity. So, what do we have here? We have here antibodies that reacts with antigens present on cell surface or in the extracellular matrix, causes disease by destroying these cells, etc. What is the main point for you that you need to remember? Antibody-mediated hypersensitivity. The problem flows in the blood. So these antibodies, they flow in the blood and they fix or have a binding only with the specific cells, but these cells, specific cells, are normal cells. They do nothing wrong, absolutely. But in the blood, circulating specific antibodies that want to kill these normal cells. Classical examples. First of all, transfusion reactions, in which cells from an incompatible donor react with and are opsonized by performed antibody in the host. So what's wrong? We have erythrocytes with different amount or with different structures of proteins. These proteins with different structures are considered as antigens because they have a different structure. And that's why our organism try to kill proteins, try to destroy proteins with different structure. Next example, hemolytic disease. So classically, when mother has negative rhesus and its child, her child, has a positive rhesus. Next one, autoimmune hemolytic anemia and some drugs reaction. Here, instead of antigen, we use term hapten. So when you read the literature, there's some information and see the word hapten, it means about some problems with drugs, problems with autoimmune response against these drugs. So we have three main mechanisms of the second type of hypersensitivity reaction. So first of all, it could be opsonization and phagocytosis. Secondly, complement and Fc receptor mediated inflammation. And last one, antibody mediated cellular dysfunction. We have three main mechanisms, and according to each mechanism we could find different disease. Let's discuss what disease has what mechanism. So, for example, autoimmune hemolytic anemia has problems, so the way of problem, the pathogenesis, through opsonization and phagocytosis of the red blood cells. Next one, for example, Pemphigus vulgaris, exactly antibody-mediated activation of proteases, disruption of intracellular adhesions. Next one, Goodpasture syndrome, complement and Fc receptor mediated inflammation. Myasthenia gravis, antibody inhibits acetylcholine binding down modulates receptor. And Graves' disease, antibody mediated stimulation of TSH receptor. And right now discuss each disease. So again, hemolytic disease, you see jaundice. Yes, so you see yellowish color of the skin. This is jaundice. Type of the jaundice is hemolytic or prehepatic jaundice. So accumulation mostly non-conjugated bilirubin, because we have death of erythrocytes, of huge amount of erythrocytes. Why? Because in our body we have some antibodies against the erythrocytes. Move on. Thrombocytopenia. So when we have problems with amount of platelets, in this case we have a lot of hemorrhages. So as you see, this looks like a rash, but this is not exactly rash. How can we distinguish? Is this rash or this is hemorrhage? We need to press this field of the skin. So if we press and there is no more red color, this is classical rash. Classical like due to infectious disease. If we press and there is no changes, this is hemorrhage. And thrombocytopenia is one of the disease that is characterized by exactly hemorrhages. So, Pemphigus vulgaris, gross appearance, you see like pustules. So, microscopically we have exudate, inflammatory fluid. Again, gross appearance, so even with ulceration, so After this pustose rupture, we have an ulcer. We have an ulcer here. You can also see the ulcer. So microscopically, a lot of fluid and also a lot of neutrophils, and you see with significantly pinkish cytoplasm. So these are eosinophils. Eosinophils is very common, presence of eosinophils is very common feature for autoimmune reactions or reactions of hypersensitivity. Vasculitis, and here you need to remember one main point. Classically, systemic vasculitis is a feature for third type of hypersensitivity reactions. But some diseases from the second type of hypersensitivity reaction could be characterized by vasculitis as well. But classically, systemic vasculitis, this is third type of hypersensitivity. So, but microscopically, there is no change. So, this is fibrinoid necrosis of the vessels where we have inflammation. So, in the surrounding tissue, we have a lot of neutrophils and a lot of, as you see, cells with more eosinophilic cytoplasm, with more pinkish cytoplasm. So these are eosinophils. Move on, Goodpasture syndrome. So here we have problem with reaction immune system against the collagen. So what we have? We have collagen in the glomeruli and in the lung wall of the alveoli. So mainly in the Goodpasture syndrome we have two locations of the clinical manifestation. So first location is problems with kidney. Here we have glomerulonephritis, and in the lung we also have problem, and this problem could lead to even severe hemorrhages. So our organism thinks that some parts, exactly collagen type 4, should be destroyed. So this is classical appearance of glomerulonephritis, where we have problems with exactly base structure of basement membrane, collagen type 4. Again, so this is immunofluorescence, and what this immunofluorescence actually shows us: accumulation of complement everywhere. So everywhere in the glomeruli. So kidney looks like acute glomerulonephritis, so with reddish, with many or multiple reddish dots on the surface of the kidney. Next important, Graves' disease, and I also at once show you next slide, Hashimoto thyroiditis, and we need to compare these two diseases. Both of them are characterized by problem with thyroid gland, but Graves' disease leads to the hyperthyroidism, and thyroiditis Hashimoto finally leads to the hypothyroidism. So both of them are second type of hypersensitivity reaction. But remember, we have three main mechanisms. So Graves' disease, here we have antibody against the exact hormone. You remember, receptor of the thyroid stimulating hormones. So exactly to the hormone. And that's why our organism thinks. So I stimulus, so brain thinks, I stimulus to produce more T3, T4, and I send thyroid stimulating hormone. But there is no reaction. So I need to stimulate more and more and more. And what we have in the result? We have increased amount of the parenchyma of the thyroid gland, because our organism stimulates more and more to synthesis T3 and T4. On the other hand, due to the Hashimoto thyroiditis, we have also antibodies, but antibodies against exactly follicular epithelium of the thyroid gland. So when we have Graves' disease, our organism thinks that the bad guy is the receptors for TSH or T3, T4. According to the Hashimoto thyroiditis, our organism thinks that bad guys are follicular epithelium, so cells of the follicular epithelium, and destroys, our organism destroys them. Main classical microscopical appearance here is presence of lymphoid follicles within tissue of thyroid glands. Here you see antibodies attack the thyroid gland. So, in the result of the Hashimoto thyroiditis, we have sclerosis and atrophy of the thyroid gland. That's why we have hypothyroidism. So, in other words, deficiency of the function of the thyroid gland. So please remember about Hashimoto thyroiditis and Graves' disease. They are completely different disease because they have different mechanisms of the second type of the hypersensitivity reactions. Move on. Acute rheumatic fever, exactly myocarditis with formation of so-called granuloma, rheumatic granuloma. Next one, endocarditis. Classically, this endocarditis affects mitral valve, and we actually talked a lot about the rheumatic fever, so we have already studied this disease when we talk with when we said about Browning duration of the lung, when we said about the chronic cause of the chronic heart failure, and that's why systemic congestion and also changes in the lung like congestion. Again, brown color due to the hemosiderin. And also we said about rheumatic fever, endocarditis especially, when we are talking with you about thromboembolism, because on the mitral valve, on exactly on the surface of the mitral valve, there is a possibility to formate thrombi, and this thrombi could become thromboemboli and could cause infarctions of the brain, liver, spleen, kidney, intestine, etc. Move on. Third type, immune complexes. So, who are bad guys in this situation? So, bad guys in this situation, exactly combination of antigen plus and antibody. So, antigen binds the antibodies exactly within lumen of the blood. It's important. So, when we're talking about the first type of hypersensitivity reaction, immunoglobulins E fixed on the surface of the mast cell. And there is no antigen in the organism. Second type of hypersensitivity reaction, antibodies flow in the blood, and antigens are considered actually as normal cells, or oppositely, some normal cells are considered as antigens. And third type of hypersensitivity, antigens and antibody both, they flow in the blood, so they combine, they bind and flow within lumen of the vessels. And logically, the first barrier, the first border will be wall of the vessel. That's why we have two types. So first of all, this is systemic hypersensitivity and local, so-called aqueous reaction. So systemic means, as I said already, systemic vasculitis classically. All systemic, mostly, not all, mostly all systemic vasculitis are characterized by third type of hypersensitivity. Local, when we focally invite the antigen. Again, several types. Several times. So, examples of the third type reaction. So, classically, SLE, systemic lupus erythematosus. This is one of the most common questions in your MCQ, so just memorize. Systemic lupus erythematosus is third type of hypersensitivity. Next one, Poststreptococcal glomerulonephritis. This is very common and very tricky question. What's going on? What does it mean, poststreptococcal? So, patient had roughly 1 month, probably 3 weeks ago, streptococcal infectious. It could be either angina, or it could be rheumatic fever. So this usually they are children. Classically, I can say classically, they are children. So after this disease, so through no less than 3 weeks, patient suffers from problems with firstly urine. it becomes reddish. So one of the main clinical symptoms of glomerulonephritis. Why it happens? The main reason is we have accumulation of the immune complexes in the blood. And these immune complexes just settle in the glomeruli of this patient and cause glomerulonephritis. Okay, move on. Polyarthritis nodosa, reactive arthritis, serum sickness, and obviously arthritis reaction, more like experimental, but in some literature you could find information about the situation when we have injections of some drugs, medical drugs, in the same place, and there is some necrosis of the lumen of the vessel, of the wall of the vessel, and also we could find inflammatory reaction. So all features of third type of hypersensitivity, but exactly in the place where we invaded the substance. So, classical appearance, you need to memorize this one. So we have firstly accumulation of antibodies. So firstly presentation of the antigen to B cell, then B cell becomes plasma cell, then plasma cell synthesis antibody. This antibody binds with the same antigen that was presented for B cell. So this antigen-antibody complex fix on their intima, on the surface of the intima. Then we have activation of the complement mostly, and obviously some accumulation of the neutrophils, and due to this accumulation of the complement. Then we have inflammation of the wall, and we can name this inflammation as the vasculitis. I underline vasculitis. So classically, the third type of hypersensitivity reaction causes systemic vasculitis. So systemic lupus erythematosus. In your MCQ, there is a description of young woman with specific rash on their face, but not only on their face, it could be everywhere. So as you see, vessel, and vessel is surrounded by inflammatory infiltration. So exactly inflammatory infiltration within the wall of the vessel. That's why we can say that this is vasculitis. Next one, possible situation for endocarditis. Liebman-Sachs endocarditis, as you see, features, as you see, damage of the surface of the endocardium due to the systemic lupus erythematosus. Again, so here endocardium is the intima of the wall of the vessel. So heart is the main one of the type of the vessel. Move on. Poststreptococcal glomerulonephritis. We have here again accumulation of the immune complexes of the surface of the surface of the endothelium of the glomeruli. So what do we have? So-called linear accumulation of immune complexes. Serum sickness. When we have some injection in the blood with some drugs, for example, and we have allergic reaction for this drug, systemic allergic reaction for this drug or against this drug that we inject, invade in the blood. And I underline again several times. And the example of local situation, Arthur's reaction, when we also invade some drug, but invade mostly in the muscle, not in the vein exactly. So, and we find all features of inflammation again, but the mechanism of development is the third type of reaction, because microscopically we could find vasculitis and even necrosis of the wall of the vessel. Also, Arthur's reaction could be made worse by thrombosis because of the platelet aggregation. Why do we have this situation? Because we have, remember, we discussed with you Virchow's triad. When we have damage of the intima of the vessel, this is one of the cause of thrombus formation. So that's why platelet aggregation only makes worse the situation with ischemia due to the vasculitis. Why we have ischemia? Because vasculitis, so this is inflammation, this is edema, yes, because due to the inflammation we have increased vascular permeability, we have increased amount of the extracellular matrix within wall of the vessel. So that's why we have more narrow lumen of the vessel. That's why we have some ischemia in the tissue that is supplied by this vessel, by this artery exactly. And last one, fourth type of hypersensitivity reaction, cell-mediated. I underline, when we are talking about the second type of hypersensitivity, we said that this is antibody mediated or antibody mediated cytotoxicity. When we are talking about fourth type, we can say that this is cell mediated cytotoxicity, but both of them, I mean second and fourth, kill that cell, exactly kill that cell. Also, in some literature, you can find that fourth type of hypersensitivity is the so-called dilated type hypersensitivity. And first three, first, second, and third, are immediate type hypersensitivity. But this is not actually accurate to name first, second, and third like immediate, because really immediate is only the first type. Second and third actually could take more, for sure, more than several minutes. So really immediate is only the first one. That's why more correctly, when you will answer the question what types of hypersensitivity do you know, like the first one, second one, third and fourth, and name these numbers. So immediate or anaphylactic, antibody-mediated cytotoxicity, immune complex mediated hypersensitivity, and cell or T cell mediated hypersensitivity. Move on. Again, we have two main mechanisms according to what type of T cell is involved. So when we're talking about CD4, so inflammation is caused by, as you see, cytokines that activated inflammatory cells, neutrophils and macrophages. When we're talking about CD8 T cells, they actually injure the tissue on their own, so personally. And again, it depends what disease do we have, according to what mechanism we could explain. So, examples. Rheumatoid arthritis, the first one. I please you to add in the list of different diagnoses that you need to differentiate. So firstly, we have rheumatic fever. Remember that rheumatic heart endocarditis, rheumatic heart myocarditis. We have also a systemic lupus erythematosus, and this is the third type. Rheumatic fever is second type, and rheumatoid arthritis is fourth type. And we classically will be so this disease should be differentiated. And in your MCQ, classically, you will find the distractors like rheumatic fever, SLE, rheumatoid arthritis. So you very often need to choose one out of the three. So please try to memorize it right now. I mean, during the topic immune pathology, and make your life for sure more easier in the second semester. So what else here we have? We have first type of diabetes mellitus, and also we have here inflammatory bowel disease. We discussed this one. So two diseases, ulcerative colitis and Crohn's disease, we will see. And also psoriasis. Psoriasis is also caused by fourth type of hypersensitivity reaction. So mechanisms, as we said, so when we have CD4, so activation of the macrophages to produce some cytokines, some interleukins that could find and recruit leukocytes to produce the inflammation, to promote actually the inflammation. And CD8, when we have exactly damage of the cell, and this damage, this injury of the cell is caused by cytotoxic influence of the CD8 T lymphocyte. So again, initial contact with antigen. So macrophage eats it, then see or actually show to the naive T cell. And second contact with antigen. So T cell have already memorized, so it remembers this antigen. And then it calls to the macrophage and tries to make an inflammation. So right now we discuss with you the term, the term granulomas formation with the multinucleated giant cell through one slide. So, clinical examples of CD4 T-cell mediated inflammatory reactions. So, classical example is the tuberculin reaction. So, what is this exactly? So, patient in our country usually after the delivery, the next day or exactly during this day after the delivery, the infant gets some vaccination, and this vaccination contains actually Mycobacterium tuberculosis. So our organism starts to produce antibodies against this Mycobacterium. And while our organism has these antibodies, our organism is considered as protected against tuberculosis. So, what is tuberculin reaction? We inject in the muscles, not in the veins, in the muscles, some protein of the cellular membrane, of the membrane of the Mycobacterium tuberculosis. So this protein has the same structure as the cellular membrane of the Mycobacterium tuberculosis. And if we see the reaction through no less than 72 hours, so increased, so we see the changes in the skin, on the skin. If we see these changes, in this case exactly, we could think that this organism is protected. So our organism shows that it has already had antibodies against this protein, against this tuberculin. So if there is no reaction, so we injected the tuberculin and there is no changes on the skin. It means that there is no Mycobacterium tuberculosis in the organism and there is no immunity in this organism, and we should revaccinate this child again, because there is no immunity against tuberculosis. On the other hand, when we have excessive reaction, so it should be, for example, no more than 12 or 10-12 millimeters, and we have excessive reaction, like for example 30 or 40 millimeters. So what does it mean? It could, I underline, not like it could mean that this child has a disease. So excessive reaction could mean that there are excessive amount of antibodies in the organism, and that's why the reaction appears actually more quickly and more severe. That's why this child should be checked. Probably this child has a tuberculosis. It's really important not to mislead the problem and not just skip this problem. Okay, and diseases and what we said about the granuloma formation. So there are three main diseases, but actually there are more than three, and we have already studied with you chronic inflammation, and we have so-called granulomatous inflammation, infectious and non-infectious. So tuberculosis, the classical example of granulomatous inflammation, hypersensitivity reaction type 4. Sarcoidosis is also, we have non-caseous granuloma. So in the tuberculosis there is caseous necrosis. During the sarcoidosis we have granulomas formation, but without caseous necrosis in the center, but with multinucleated cells as well, and some presence of fungal infection. So what's going on? So here we have CD4, as you see, activation of the CD4 T lymphocytes, and TNF, tumor necrotic factor, and interferon gamma. So activation of the monocytes, they become macrophages, then macrophages become so-called epithelioid cells, and these epithelioid cells become some giant cells. So this is main structure or main scheme of granuloma formation. So again, granuloma formation is a type of type of hypersensitivity reactions. So rheumatoid arthritis, changes in the joints, mostly or predominantly small joints, whereas according to the rheumatic fever we have changes in the gross joints like elbow, knee, etc. So this slide shows us late stage or last stage of rheumatoid arthritis with severe significant deformation of the joints and obviously presence of some ankylosis. Next, Crohn's disease and ulcerative colitis, classical, I can say like love words. So always we need to differentiate, is it Crohn's disease, is it ulcerative colitis? So again, we have already discussed a bit this topic. So I repeat again, and I hope you memorize. So Crohn's disease has a possibility to jump. So this is very, I can say, like, funny guy who likes jump, who likes to jump. So that's why Crohn's disease affects different type of large intestine and could affect also small intestine. Ulcerative colitis, on the other hand, usually affects terminal part of the large intestine. It's important. Terminal part of the large intestine. There is no jumping. There is only one focus. That's it. Crohn's disease jumps. Ulcerative colitis, closely to terminal part of the large intestine. So there is no problems in the small intestine compared with Crohn's disease. Move on. What you can use like a key word in your MCQ? So-called gobblestoning. Gobblestoning. What does it mean? You see, like stones in the road. So these stones exactly are granulomas. And ulcerative colitis, we have more bigger amount of the tissue that invades in the lumen of the colon. So-called pseudopolyps. Why these are pseudopolyps, not like a polyps? So we studied with you during the one type of the chronic inflammation. This is formation of the polyps and the condylomas. So this is pseudopolyps. So is not a true polyp. Why? Because we have an ulceration, so defect of the defect of the mucus, and then we have a focus of the survived mucus, and then again focus of the ulcer, so deep defect of the mucus. That's why this island of survived mucus looks like polyp. But this is not a true polyp. This is so-called pseudopolyp. So, appearance of the Crohn's disease. So, this gobblestoning, so-called, as you see, jumping. So, here something, here something, here something, and mostly normal mucus, And microscopically, so no cases granulomas with giant multinucleated cells. This is a key feature, microscopical feature for Crohn's disease. And the ulcerative colitis. As you see, whole wall of the colon is affected without any non-affected area. And significant inflammation with a lot of plasma cells and eosinophils and formation of so-called crypt abscesses. Also, so microscopical feature for ulcerative colitis, plasmacytes and crypt abscesses. For Crohn's disease, presence of granulomas. Psoriasis, also common question in your MCQ about the fourth or dilated type of the hypersensitivity reaction. And the autoimmune diseases. So, first of all, what is the autoimmune diseases? What is autoimmune disease? What is this? What does it mean? Our organism thinks that the organ or type of it or some cells of it are bad and tries to destroy this organ, part of it, or some group of cells of it. We need to know about the very important point, immunologic tolerance. What does it mean? It means that we have an algorithm in our organism how we teach the lymphocytes that the proteins, the structure of the proteins of the surface of our cells or our organs, cells of the organs. So exactly these structures are normal. We have two types, two mechanisms or two places. In the central lymphoid organs and in the peripheral lymphoid organs. And according to this, we have central tolerance and peripheral tolerance. So when we destroy, so our organism destroyed that lymphocytes that think that some normal cells are bad. So if you think that, for example, hepatocyte is wrong guy and you think that you should destroy it, so you should be killed, I underline, by apoptosis. So this is the tolerance. And when something is wrong with these mechanisms, we have autoimmune disease. So our immune system destroys normal tissue and normal organs. The main causes of this situation, first of all, is inheritance. I think it's clear. So I can do not talk a lot about this situation. I underline only diseases: rheumatoid arthritis, type 1 diabetes mellitus, systemic lupus erythematosus. And also I emphasize on, as you see, so in this list there are diseases of different hypersensitivity reactions types. So move on. Infections and tissue injury. Here I can give you classical example about exactly infections like diabetes mellitus, type 1. When we are talking about, for example, child who suffered from flu while it was infant, through several years, it is a possibility to find diabetes mellitus type 1. Move on. Autoimmune diseases are usually chronic and progressive. Unfortunately, there is mostly no treatment. Only one pathogenetic treatment that we really have, we use corticosteroids just to depress the immune response. So actually, when we have when your patient has autoimmune disease and you give him or them high doses of corticosteroids, so you artificially make a secondary immunodeficiency syndrome. So because you significantly depress the immune system response. Okay, move on. Immunodeficiency disorders. So we have primary or congenital or secondary or acquired. Primary immunodeficiency, so there is a list. I won't mention each of them. During your seminar, it will be a question about this primary immunodeficiency syndrome. So I please you to know no less than one name in each group. I'd like to discuss with you more the secondary immunodeficiency syndrome or acquired immunodeficiency syndrome. I please you memorize that not only HIV could lead to the secondary immunodeficiency syndrome. As I told you, it could be due to the treatment that depresses immune system response. For example, high doses of glucocorticosteroids or due to corticosteroids because patient has autoimmune disease or patient has had transplantation of any organ, kidney, liver. In this case, we also need to depress immune system response and also gives corticosteroids. And also, patient classically has problems with immune system response when this patient takes a chemotherapy. So in this case, also immune system response is completely depressed. Okay, and right now discuss exactly HIV. So, manifestation of HIV is characterized by presence of opportunistic infections, secondary neoplasms, and neurologic manifestation. What is opportunistic infections? So, opportunistic infections means that this infection, this microorganism, or this, for example, type of fungal infection, normally, I underline normally, could be present in our organism. But this type does not lead to disease. Only due to the depressed immune response, this type of infection causes the disease. So, three main routes of transmission. I think it's clear. I underline this one. HIV is a non-transforming human retrovirus. Non-transforming. You know, for example, virus of the influenza could transform, yes? And that's why we have a new vaccine each year. HIV is a non-transforming human retrovirus. So, life circle. First of all, we have presence of the virus. Then it combines with specific proteins, invades in the membrane. Then we have replication of the virus, and virus release. I'd like to underline that problems due to the HIV is not only about T lymphocyte. Yes, lymphopenia, predominantly caused by selective loss of the CD4 helper T cell subset. Yes, this is classical and this information is absolutely well known. But as you see, there are a lot of problems with other types there are a lot of problems of other counterparts of immune system response. So as you see, problems with B cell activation and even with macrophage functions. So very quickly, how this virus invites and what response we have. So first of all, infectious of mucosal tissue. Next one, we have death exactly of mucosal CD4. Then this infection appears in the lymph node. Then we have viremia, so virus appears in the blood. So spreads via blood. And then we have immune response, so anti-HIV antibodies. But this is so-called clinical absence of the symptom. So clinical latency. So mostly no clinical manifestation. And only when we have increased viral replication, we have so-called AIDS. But AIDS actually is the final stage of the HIV infection. You need to remember. So we have several stages of the HIV infection. First stage is latent, so there is no clinical manifestation at all. Next one stage when we have generalized increased lymph nodes. Next one is pre-AIDS. And last one is AIDS, exactly AIDS. Mainly or predominantly, clinical manifestation is characterized by pre-AIDS and AIDS. So, opportunistic infectious. This is a huge list. Right now we discuss with you some of the most common. So, first of all is B cell lymphoma. Right now we have not studied yet this topic, so tumors. This is our next seminar. But lymphoma, this is a malignant tumor that origins from, in our case, B lymphocyte. So B cell lymphomas is common complication of pre-AIDS and AIDS stage of the HIV infection. Why do we have? Because, as I said, there is not only with T cell problem. With B cell we have as well. So first of all, here we have germinal center B cell hyperplasia. That's why we have mostly Burkitt lymphoma and large B cell lymphoma. Also, it could be unchecked reactivation of EBV, Epstein-Barr viruses, or Kaposi sarcoma viruses. And in this case, we have either B cell, large cell B cell lymphoma or Hodgkin lymphoma. Next one, pneumocytosis, so infections of the lung by, as you see, Pneumocystis carinii. So, specific stain can show us the exact cause of this situation. Toxoplasmosis, this is electron microphotograph, and this is classical appearance of the cause of this disease. Candidiasis, this is the most common answer in your MCQ. So we have oral cavity and some whitish dense plaques in the oral cavity, in all surfaces you see, and on the tongue as well. Cryptococcosis, classically brain is affected, so presence of cocci. And last one is Kaposi sarcoma. As you remember, 1 minute ago I told you about the probable unchecked reactivation of the virus that could lead to this sarcoma according to the presence of HIV infection. So, Kaposi sarcoma is a malignant tumor as well. This is sarcoma because the origin of this tumor is mesenchymal tissue. This is angiosarcoma. So, because you see a lot of erythrocytes out of the lumen of the vessel. So, erythrocytes out of the lumen of the vessel. Grossly, we have a lot of here more like brownish, but usually dark blue or red blue color, some plaques on the surface of the skin, multiple plaques. Okay, so this is HIV infection, and this is one of the example of secondary immunodeficiency syndrome, but I underline one of them, not only the one. And our last part, amyloidosis. So, amyloidosis, exactly what is this? So, this is a condition associated with the number of inherited and inflammatory disorders in which extracellular deposits of fibrillar protein are responsible for tissue damage. So, remember, we have studied with you during the first seminar extracellular accumulation, and one of these type of the extracellular accumulation is accumulation of amyloid. Here the mechanism, one of the mechanisms according to our Z classification of mechanisms of the accumulation, we can name like abnormal synthesis. So synthesis of that substance that normally does not exist. So we have different types of amyloid. So AL so-called amyloid light chain. Why? Because this protein is made up of complete immunoglobulin light chains. AA protein, this is so-called non-immunoglobular protein. So this is so-called amyloid associated type. So it synthesis by liver cells. Also, we have beta amyloid protein. Classically, we could find it in the Alzheimer's disease. Last one is so-called TTR protein. TTR is transthyretin. This is a normal serum protein that binds and transports tyrosine and retinol. But some mutant form of this protein could bind with actually with amyloid, so becomes amyloid. And this is another another type of the amyloid. Also, it is known about the beta-2 microglobulin and some prion proteins aggregation could also be considered as amyloid. Anyway, for you, the most important to remember about these types. And the main classification of amyloidosis. So first of all, it could be as usual general or systemic or localized or so-called hereditary amyloidosis. This is the new classification, the most new. So you see the type of the fibril protein and also some diseases. I'd like you to use more this classification. I deliberately put this second slide about the classification of amyloidosis. So, primary amyloidosis, lymphoproliferative disorders with amyloid, and the secondary amyloidosis. So, primary amyloidosis means there is no preceded history with disease. Secondary amyloidosis, that we have some or we had some disease previously, and right now we have a complication. And these chronic infections and chronic inflammations, one of the most common question in your MCQ. So, classically, in your MCQ, patient has fibrocavernous tuberculosis, rheumatoid arthritis, or what else? Or chronic purulent inflammation. For example, chronic abscess. Why not? So, tuberculosis, rheumatoid arthritis, and chronic purulent inflammation. So, patient suffers around 10 years or 5 years. And right now, patient complains on problems with urine, with kidney, anything else. What's wrong? Secondary amyloidosis of the kidney. This is the most common question in your, one of the most common question in your MCQ test. Secondary amyloidosis. Lymphoproliferative disorders, classically plasmacytoma. Plasmacytoma, this is the focal name of multiple myeloma. So disease is the same. When we have local form, this is plasmacytoma. So it derives from plasmocytes. When we have systemic changes, so this is multiple myeloma. Okay, I hope this is clear and we could move on. Gross appearance of the spleen. So the most common, again, question during the seminar, during the practical classes, we discuss with you changes in the spleen due to the amyloidosis. So what do we have? We have firstly, first stage is sago spleen. So we have some just focuses, small focuses of more whitish yellowish with whitish yellowish color, and that's it. And then the second and final stage will be Lardaceous spleen. It means when whole spleen is more like whitish yellowish color and only several small focuses of normal spleen. So two stage, sago spleen and Lardaceous spleen. And right now, gross appearance. So we have here, as you see, some more yellowish, more whitish, more lightish focuses, small, you see, small focuses, like a dots probably. When we're talking about, remember, when we were talking about nutmeg liver, we said about the reddish dots, yeah? So here it could be something like a more yellowish, more whitish dots. And the last one, Lardaceous spleen, when the spleen has a unique appearance, so mostly whole spleen instead of dark red, as you see, becomes whitish yellowish. And microscopically, you see the accumulation of unstructured pinkish masses, pinkish due to the HE staining in the spleen, and reddish masses in the glomeruli, because this is specific stain with Congo red. I underline again. So we have amyloidosis as a possible autoimmune problem. But generally, amyloidosis is extracellular accumulation of abnormal protein, like hyalin. But when we use specific stain like Congo red, we do not have a reaction if this is just hyalin. We have a red appearance when we are talking about exactly accumulation of the amyloid. And again, I underline, when we are talking about the most common type of amyloidosis, according to its classification, it will be secondary amyloidosis due to the chronic destructive infectious disease. Okay, guys, finally, that is over. The lecture is over. It's really difficult topic. It's really difficult lecture. I am absolutely exhausted after it. If you have any question, please type. If you will have questions during your practical classes, ask your teachers. but I can assure you that if you really get into this topic today, next semester, you feel free. You really feel free time, because this topic covers a lot of diseases. This topic covers a lot of pathological situations, a lot of pathological processes as well. So if you really get into and understand what's going on and where is the difference between hypersensitivity reactions, autoimmune diseases, problems with immune system, so immune deficiency syndromes, you really actually cope with significant part of our subject. So I wish you luck with this topic. So, and I underline again and again, if you have questions, our department is always ready to help you. So have a nice day. See you next time. Thank you for your listening, and obviously stay healthy.